Welcome to MedSimu Pathology Podcast. This is our very first exploration together, and I'm really glad you're tuning in.
It's great to be here.
Today we're diving into something really fundamental in pathology: how our cells and tissues adapt when things change around them. Think of it as laying the groundwork for understanding so many diseases you'll come across. We're focusing on these growth adaptations, how organs respond to stress at the cellular level.
Absolutely. And I'm happy to be here to walk through these concepts.
Fantastic. Our colleague here is the expert who will guide us through the real details of these biological responses.
It's a pleasure, understanding these basic adaptations, things like hypertrophy, hyperplasia, atrophy, metaplasia, and even dysplasia is just so foundational.
Couldn't agree more.
And we shouldn't forget the developmental side, too, like aplasia and hypoplasia. We'll look at, what causes these changes, what they look like, and crucially, what happens next, the consequences, especially for disease.
Exactly. We'll stick to the core concepts, aiming for clear explanations, good examples, stuff that's useful whether you're a med student or a doctor hitting the books for boards.
Making it stick is the goal.
Right. So let's start. Organs like stability, don't they? Homeostasis.
That's the core idea, yes.
Yeah.
An organ tries to maintain its equilibrium, its normal function, despite the stresses it faces.
So physiological stress.
Exactly. But when that stress changes, maybe it increases or decreases or even just changes type, the organ needs to adapt. And these growth adaptations are how it tries to cope.
Okay, let's take increased stress first. Logically, that often means the organ gets bigger.
Usually, yes. Increased demand often leads to increased organ size. And this happens mainly through two processes: hypertrophy and hyperplasia.
Okay, hypertrophy and hyperplasia. What's the key difference?
So hypertrophy is all about the size of the individual cells increasing. They get bigger.
It's bigger.
Well, it's more complex than just swelling. It involves activating genes, making more proteins, producing more internal structures, more organelles. The cell itself bulks up its machinery.
Got it. And hyperplasia?
Hyperplasia is different. It's an increase in the actual number of cells.
More cells?
Yes, usually through the production of new cells from tissue stem cells.
So hypertrophy is bigger workers, hyperplasia is more workers.
That's a great way to think about it. And often you see both happening together.
Like in pregnancy. The uterus.
Exactly. The uterus is a perfect example. The muscle cells get bigger hypertrophy, and you also get more muscle cells hyperplasia. Both contribute to the necessary enlargement.
But not all tissues can do both, can they? What about permanent tissues?
Ah, good point. Yes, permanent tissues, that's your cardiac muscle, skeletal muscle, and nerve cells. They have very little, if any, ability to make new cells once you're mature.
So they can't undergo hyperplasia.
Correct. When they face increased stress, their only option really is hypertrophy. Think about the heart in someone with chronic high blood pressure.
The heart muscle gets thicker.
Precisely. The individual cardiac myocytes enlarge to handle that increased workload. They can't just divide and make more heart cells.
Okay, that makes sense. Now, you mentioned hyperplasia can sometimes be problematic. Pathologic hyperplasia.
Yes, that's an important distinction. Pathologic hyperplasia, an increase in cell number driven by some disease state or abnormal stimulus, can sometimes be a slippery slope.
How so?
Well, it can progress. It might lead to dysplasia, which is disordered cell growth, and sometimes even to cancer. Endometrial hyperplasia is a classic example.
The uterine lining.
Right. Excessive estrogen stimulation can cause the endometrium to proliferate too much, and if that persists, it can lead to atypical cells and eventually endometrial cancer in some cases.
But there's that exception you hear about all the time. BPH, benign prostatic hyperplasia.
Ah, yes, BPH. That's a really important one. It involves hyperplasia, an increase in the number of prostate cells, causing the gland to enlarge. Very common in older men.
But doesn't increase cancer risk.
Correct. Despite the name hyperplasia, BPH is not considered a premalignant condition. It doesn't increase the risk of developing prostate cancer. It's a separate process, likely related to hormonal changes with aging.
Okay, good clarification. So that's increased stress. What about the opposite? Decreased stress?
When stress or demand on an organ decreases, the organ tends to adapt by shrinking. This is called atrophy.
Shrinking, so less work, less organ.
Pretty much. Think about muscle wasting when you have a cast on your arm that's disuse atrophy, or reduced hormone stimulation leading to shrinkage of an endocrine gland, or decreased blood supply or nutrition.
And how does it shrink? Just smaller cells?
It's actually both. Atrophy involves a decrease in cell size and often a decrease in cell number.
Cell number 2, how does that happen?
The decrease in cell number is primarily through apoptosis-programmed cell death. getting rid of excess cells in an orderly way.
Okay. And the smaller cell size?
That involves a couple of key pathways. One is the ubiquitin-proteasome system.
Ubiquitin. The tag for destruction?
Exactly. Cellular components, especially proteins like the intermediate filaments of the cytoskeleton, get tagged with ubiquitin. Then the proteasome, which is like the cell's garbage disposal, degrades them. This breaks down the internal scaffolding, allowing the cell to shrink.
And the other pathway?
Autophagy, literally self-eating.
Sounds dramatic.
It is, in a way. The cell creates these vesicles, autophagosomes, that engulf worn-out organelles or bits of cytoplasm. These then fuse with lysosomes.
The bags of digestive enzymes.
Right, and the contents are broken down and recycled, so both ubiquitin proteasome and autophagy help reduce cell size during atrophy.
So the cell basically downsizes, gets more efficient when resources are low or demand is less?
That's the essence of it, a survival strategy.
Okay. Let's shift gears again. What about metaplasia? This one's always seemed interesting, changing cell type.
Metaplasia is fascinating. It happens when the type of stress changes. The tissue responds by swapping out one mature, differentiated cell type for another mature cell type that's better equipped to handle the new environment.
So it's not just size or number, but the actual kind of cell.
Exactly. A fundamental change in cell identity within that tissue layer. It's most common in surface epithelial linings of tracts and organs.
And the classic example has to be Barrett's esophagus, right?
Absolutely. Barrett's is the poster child. Normally, your esophagus has squamous epithelium, good for handling food going down.
Right.
But with chronic acid reflux, that squamous lining gets constantly damaged by stomach acid.
A stress it wasn't designed for.
Precisely. So through metaplasia, it gets replaced by columnar epithelium, similar to the kind found in the intestines, which has mucus production and is much more resistant to acid damage.
So it's adaptive initially, a protective change.
Yes, the metaplastic columnar cells are better suited for that harsh acidic environment.
How does that switch happen? Do the squamous cells just change?
Not exactly. It's believed to happen through the reprogramming of stem cells in that epithelial layer.
Ah, the stem cells again.
Yes. The signals they receive change due to the chronic irritation, causing them to differentiate into columnar cells instead of squamous cells as they replace the damaged lining.
Is it reversible? If you treat the reflux?
Theoretically, yes. If
Yeah.
you remove the stressor in this case, control the acid reflux effectively, the metaplasia can potentially regress, and the normal squamous lining might return over time.
But there's always a but in pathology, isn't there? Persistent stress.
There often is. While metaplasia is adaptive, it's not always a stable or perfect solution if that stress, that acid exposure, continues relentlessly.
Trouble.
It can lead to trouble. The metaplastic tissue itself can develop dysplasia, disordered growth.
Dysplasia. We'll get to that.
Right, and that dysplasia in Barrett's can then progress to adenocarcinoma, a type of esophageal cancer. So metaplasia can be a stepping stone.
Are there metaplasias that aren't risky like that?
Yes, there are important exceptions. Apocrine metaplasia of the breast is one.
Okay.
You see these cellular changes, but it's not linked to an increased risk of breast cancer. It's considered benign.
Good to know. The reading also mentioned vitamin A deficiency.
Ah, yes. Vitamin A is crucial for the normal differentiation of many specialized epithelia.
Like in the eye.
Exactly. Deficiency can cause metaplasia in the conjunctiva. The normal non-keratinized squamous epithelium can change into a keratinizing squamous epithelium like skin.
That sounds bad for vision.
It is. It's called keratomalacia, and it can lead to blindness. Shows how vital normal differentiation is.
And it's not just epithelia. Connective tissue can do this too.
It can. Mesenchymal metaplasia. The classic example is myositis ossificans.
Bone forming in muscle.
Right. After significant trauma to a muscle, the connective tissue within that muscle can undergo metaplasia and actually turn into bone.
Wow. Okay, so that's metaplasia. Now, you mentioned dysplasia arising from it sometimes. Let's talk about dysplasia itself. It sounds ominous.
It definitely is a step closer to cancer. Dysplasia means disordered growth.
Disordered how?
You see variations in cell size and shape. The nuclei might look abnormal, larger, darker, irregular, and the overall arrangement of cells within the tissue loses its normal, orderly architecture. It's often considered a precancerous condition.
Precancerous, like CIN in the cervix.
Exactly. Cervical intraepithelial neoplasia, CIN, is a prime example of dysplasia that precedes invasive cervical cancer.
And where does it usually come from? Does it just appear?
It typically arises in a setting of chronic irritation or injury, often developing from long-standing pathologic hyperplasia or metaplasia. The cells have been under stress, adapting, and then the growth control mechanisms start to fail.
So it follows those earlier changes sometimes. Is it reversible?
Like metaplasia, dysplasia is theoretically reversible, especially in earlier stages. If you remove the stressor causing it, like treating the HPV infection causing CIN, the dysplastic changes can regress.
But if the stress continues?
If the stress persists, dysplasia is more likely to progress. It can become more severe and eventually cross the line into carcinoma invasive cancer, and at that point, it's generally considered irreversible.
Okay, that leaves us with aplasia and hypoplasia. These sound different, more developmental.
Yes, exactly. These aren't adaptations to stress in the same way. They relate to problems during embryogenesis development before birth.
So aplasia.
Aplasia is the complete failure of cell production during development. The organ or tissue simply doesn't form.
Like being born with only one kidney?
Precisely. Unilateral renal agenesis is a classic example of aplasia.
And hypoplasia?
Hypoplasia is less severe. It means there was cell production, but it was decreased during development. So the organ forms, but it's abnormally small.
Smaller than it should be.
Right. A well-known example is the streak ovary seen in Turner syndrome, where the ovaries are underdeveloped due to insufficient cell production during fetal life.
Okay, that clarifies those terms. So let's try and pull this all together. We've walked through quite a bit.
We have the core growth adaptations.
Right. We have hypertrophy and hyperplasia getting bigger or making more cells, usually due to increased stress.
Check.
Then atrophy, getting smaller, fewer cells from decreased stress or resources.
Correct. Driven by apoptosis and breakdown pathways.
Then metaplasia, that swap-in cell type to handle a new kind of stress, like in Barrett's.
The cellular chameleon act, yes.
Followed by dysplasia, the disordered precancerous growth that can arise from chronic stress or those earlier adaptations.
A very important one to watch for.
And finally, aplasia and hypoplasia, the developmental failures leading to absent or small organs.
The embryonic issues, yes.
It really highlights how adaptable, how plastic our tissues are, but also how those adaptations link into disease processes when things go wrong or persist too long. Understanding this seems absolutely key.
It truly is, and it's vital to remember, as we discussed, these adaptations are often protective at first, but that protection can come at a cost if the underlying issue isn't resolved.
Right, the potential for progression.
Exactly. And those exceptions we noted, like BPH not increasing cancer risk or apocrine metaplasia being benign, they just underscore that biology isn't always straightforward. There are nuances.
Absolutely. Well, we hope this first deep dive into growth adaptations has helped clarify these really essential pathology concepts for you.
We aim to hit the key points with useful examples.
Hopefully making it a bit easier to grasp and remember, whether you're studying or practicing. Please join us next time on MedSimu Pathology Podcast.
We'll tackle another fascinating area. Looking forward to it.